Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. More than 100,000 Americans died from drug overdoses in 2023, according to preliminary data, with the vast majority of those deaths from opioids. And based on national survey data, the federal government estimates that nearly 50 million adults have a substance use disorder. Now, despite these alarming statistics, there's a strong evidence base to support effective treatment of substance use disorders. But unfortunately, the percentage of people with a substance use disorder who report obtaining treatment is in the single digits. Well, Medicaid plays a significant role in addressing the country's drug use epidemic. And with most Medicaid enrollees covered by a managed care plan, how the plans respond to people with substance use disorders is of great importance. What do we know about how state Medicaid programs address access to effective substance use disorder treatment? That's the topic of today's episode of A Health Podyssey. I'm here with Christina Andrews, Associate Professor in the Department of Health Service Policy and Management in the Arnold School of Public Health at the University of South Carolina. Dr. Andrews and co-authors published a paper in the July 2024 issue of Health Affairs assessing the role states play in regulating the decisions that Medicaid managed care plans make regarding substance use disorder benefits. We'll discuss those findings in today's episode. Dr. Andrews, welcome to the program.
Thank you. It's a pleasure to be here today.
I'm looking forward to discussing this paper, but I think in order for our listeners to understand the chain of events, we need to sort of set the stage a bit. So if you could just start by talking about the scale of the drug use epidemic in the United States and what we know about effective treatment to go beyond sort of the quick sentence that I said in the introduction.
Yeah, sure. As you mentioned, we have about 50 million Americans right now who have an active substance use disorder. And this has really been the deadliest drug epidemic in our nation's history. We're talking about 1 in 7 people right now who are struggling with addiction. And this is a scale unlike anything we've seen previously. And I think one of the things that's made this epidemic so difficult to address has been the introduction of fentanyl in the drug supply. It's a very powerful opioid that can be up to 50 times stronger than heroin. And so in the past, while addiction could sometimes lead to overdose, with fentanyl, the chances of use resulting in an overdose of death is just so much higher. And so that's the bad news. That's the challenge that we're facing. But I think the good news is that we do have some effective treatments available, particularly for opioid use disorder. Medication treatments like buprenorphine, extended release naltrexone, methadone. These have medications that have been approved by the FDA for opioid addiction for some time now. And we have study after study showing that these medications can reduce substance use, cut risk of overdose dramatically, and in many cases even prevent return to use. At the same time, psychosocial therapies and supports are also important. And, particularly individuals who may really be in a state of crisis as a result of their substance use, who may be unhoused or really in a spiral of losses related to their addiction, may benefit especially from residential care, crisis management, psychosocial services, so that those services and medications can work in tandem to help individuals to get their lives back on track.
So we hear a lot in the public media about the drug crisis, the opioid crisis, the presence of fentanyl. I'd say I read those stories and I don't see Medicaid mentioned all that often. Your study focuses on Medicaid. I think it would really help if our listeners understood the critical role Medicaid plays in addressing the drug epidemic, because I'm not sure that that's as well known as it ought to be.
I couldn't agree more. And, a focus on distribution of overdose reversal drugs like Narcan and naloxone are so critical and an important part of our country's response to addressing the epidemic of drug-related overdose and mortality. But we also need to have a plan for helping those individuals who are struggling with overdose to get into treatment. And Medicaid is arguably the most important policy lever that we have to address the drug epidemic that we're currently facing in the U.S. Take, for example, opioid use disorder. It's estimated that about 40% of all Americans with an opioid addiction are covered by Medicaid. It is the largest payer of addiction treatment in the U.S., estimated to cover about half of all treatment. So that's a lot of money. That's a lot of investment in our system of care to treat this condition. And so the decisions that Medicaid makes about how to cover addiction treatment are really highly consequential. So as I mentioned, we have this pretty well-developed continuum of care for treating addiction. The American Society of Addiction Medicine has laid out really clearly a series of services and medications that are evidence-based and should be available to individuals who are struggling with substance use disorder. But since those decisions about coverage are largely decided at the individual state Medicaid program level, and some of our prior research that we've seen a lot of variation in what states are doing and that there are gaps along that continuum. And so I think that represents both an opportunity and a challenge to address some of these financial barriers to access to care that this population is still facing. And they're largely low income. So if Medicaid is not providing coverage for that service or medication, they are highly unlikely to actually be receiving it.
So you've explained the critical role of Medicaid, but let's now focus on managed care, because your study really looks at the relationship between the state Medicaid agency and the managed care plans. Why is it important to understand that relationship?
I'd argue that it is impossible to understand much about coverage design for addiction treatment and Medicaid without knowing what's happening in Medicaid managed care. And the reason for that is that roughly 75% of everyone in Medicaid is enrolled in a managed care plan. And the coverage they provide, particularly through the utilization management restrictions that are imposed, can vary pretty significantly than what's happening on the fee-for-service side that's typically under control of the state Medicaid program. Our research team has been working on this for several years now, and we found that the gaps in coverage for addiction treatment are often more pronounced in managed care plans than they are on the fee-for-service side. We've also found evidence of significant use of utilization management policies, such as prior authorization. Prior auth has come under significant scrutiny over the past few years due to concerns that the practice may limit access to treatment for people who need it. But we wanted to go further than simply to document gaps in coverage and sort of raise the issue that this is a problem. We really wanted to understand why some of these managed care plans seem to be providing more generous coverage, and what role regulatory policy at the state level may be playing in shaping those differences in the choices that they're making. It seems pretty straightforward that managed care plans in states that sort of take a firmer hand in defining the terms of coverage are probably going to have plans that provide more generous care. But we couldn't really find any existing research out there on how states seem to be setting the terms of coverage for plans within their state. And so we set out to do that in this work.
Okay, so this has been a long wind-up, but we've got a huge problem. We've got a large number of people who aren't getting evidence-based treatment. Many of those people are in Medicaid, and they're getting their care through Medicaid managed care plans. And so you set out to answer the question, what is the regulatory environment that states create for those managed care plans regarding substance use disorder treatment? With that long wind up, the pitch is over to you, and tell us, at least at the top level, what you found.
Sure. I think we really had three major takeaways from this work. Overall, what we found was that some states, have been quite assertive about imposing regulations on their Medicaid managed care plans, saying it's really key that you provide this full continuum of services and that the medications that people need around alcohol use and opioid use disorder are available. It's important that they be available to receive these services free of charge. But we found that half of states did not require their Medicaid managed care plans to cover, the full continuum of services that is recommended by the American Society of Addiction Medicine. And in particular, we found that services that were more intensive and expensive were less likely to be covered. And in a way, that's not surprising, given the financial constraints, that the Medicaid program has to grapple with. But I think it's a significant issue given that services such as residential treatment and inpatient care are crucial to effectively help individuals who are in a crisis and who are often most at risk for drug-related overdose and death. So that's the first point. Second, we found that states are continuing to grant MCO plans broad discretion to impose prior authorization. Roughly 75% of plans allowed it for most services, which honestly was higher than we expected to see. And around 50% of states allowed it for most medications. And so we have some evidence to suggest that prior authorizations may be serving as a barrier to accessing substance use disorder treatment, yet most states still allow their MCO plans to impose those prior authorization requirements on enrollees within their plan. My third point is that a large number of states also allow Medicaid MCO plans to make receipt of medication contingent on compliance with special kinds of requirements, such as drug testing and psychosocial therapy. These requirements are concerning in the sense that they may discourage some people from initiating or continuing in care. So there's been a fair amount of debate about whether these kinds of requirements are helpful or harmful. You can think for an example of somebody who may be interested in getting on buprenorphine, but doesn't necessarily have the time or interest to also engage in some form of talk therapy concurrently. Some plans may deny, that individual reimbursement for buprenorphine if they do not also receive therapy. And there is not a clear consensus about whether that's a good or a bad thing. But from my perspective, it seems like a limiting restriction that could restrict access to these life-saving medications for some people who need them.
Well, I appreciate the concise presentation of three major findings. I want to dig a little deeper into them and what some of the implications are of that. We'll do that after we take a short break. And we're back. I'm speaking with Dr. Christina Andrews about state Medicaid program regulation of how managed care plans restrict or provide access to substance use disorder treatment for Medicaid enrollees. Before the break, we heard the three major findings from the paper. I want to go a little deeper. As I think about as I step back and listen to how you presented it and read the paper, I'm sort of struck by this tension. On the one hand, you see most states saying, yes, you need to provide this treatment. But you're also seeing most states say, but if you want to make some barriers and hurdles that people have to get over in order to get it, you can do that too. So it's sort of like, yes, but no, or yes, but maybe, or something like that. So I just wonder if you could sort of take that tension And tell me, first of all, if that's your conclusion as well, and if so, what it means and what the implications are of that tension.
Yeah, I think that's such a great question. And we've definitely seen a pattern in the research that we've been doing that as states have been moving towards expanding coverage, when they expand coverage, they almost always do so, by adding a requirement for a prior authorization or setting specific limits on use of that service or medication. And so I think that why that's happening, is an open question in some ways. In terms of expanding coverage, I think that's exactly the right thing to do given the urgent need that we have to expand access to treatment. So that's a good thing. When states expand coverage for treatment on the fee-for-service side, MCO plans are typically required to do the same. But at the same time, when we have these state Medicaid programs that have been reticent to cover new services without also allowing Medicaid managed care plans to place some controls on their use, we don't have a clear picture of how that expanded coverage necessarily translates into access. And so, they allow these plans to set the terms, so to speak, on who can access these services and under what conditions. And in many ways, I think that's quite reasonable. But I think what creates some challenges for providers and patients, really, frankly, researchers as well, is that medical necessity criteria are typically used to make calls about, what prior authorization decisions are made, an approval or a denial. And those medical necessity criteria are often deemed proprietary and they're not available to the public. So you don't know if you will receive an approval for your request. And if you don't, it's incredibly difficult to get a clear determination as to why. So that process is opaque at best.
So, as you're describing this, it takes me back. I have to go back 3 decades. I used to run the Medicaid agency in Colorado. And it sounds to me a little bit like this is, it's sort of reflexive or inertia. As you say, you open the door and say, hey, there's a new benefit here. It's really important. But we are nervous about how much it's going to cost and how many people are going to take advantage of this. And even if it's fully evidence-based, you want to have some way to clamp down on the gate to make sure, frankly, that it doesn't bust the budget. And for the people who need the service, that's a huge barrier to access. But to the state, it's like, this is our insurance policy. If we don't have some barriers, we could just be spending money that we're not sure that we have. And I'm struck by sort of this notion of, yeah, that's kind of how it's normally done. And so that's how we're doing it with this benefit, just like we would with a new imaging technology or a new medication, perhaps, where you're just kind of nervous about what the budget implications are.
I think that's exactly right. And, after a rollout, of a new coverage policy, it may be after a few years that some of these limitations could be pulled back, depending on what they're seeing. But it does seem like that is typically the way that states and their plans open that door. Plans are, I think, have to face the responsibility of both trying to control costs while also ensuring appropriate use of care. And that's challenging to do. And so, the use of these utilization management policies is one of the key tools that they have to try to achieve those goals.
So I think thinking about this as a tension is really good. And you said, and I wonder if it's true, that, maybe some of this is just about timing, that you start with a tighter constraint, and then you hope that over time the door will open more widely. But that leads to a question, and you alluded to this a moment ago, about the utilization review criteria are usually not very transparent, to put it mildly. So I guess the question I would ask is, I'm going to frame this the way I think about it, which is maybe not exactly the same way you think about it, is that the plan is sitting there saying, this is potentially a hugely beneficial service, but it's also some of the modalities are very expensive. Um, and so when you put a utilization barrier in place, are you maximizing the clinical benefit, which would mean that you're fairly open to it, or are you keeping one thumb on the spending side of this and just saying, even though this would be very effective treatment for our enrollees, we just can't afford it based on the payments we're getting from the state. So I just wonder if you can help me think about the degree to which we really have the evidence that would enable states to make policies around what kinds of utilization controls are and are not appropriate in this domain for substance use disorder treatment relative to, as we discussed earlier, sort of the garden variety medical treatment that may be experimental or novel, that you also might want some utilization management tools for.
In short, no, it is not at all clear to me that we are making decisions about utilization management policies based on evidence. One of the interesting things that we found in some of our earlier work looking at Medicaid managed care plan use of utilization management is that these plans were more likely to impose prior authorization on buprenorphine, which is an incredibly inexpensive drug, than they were on extended release naltrexone, which is widely understood to be a very expensive medication. So that's an interesting question, right? Why is that the case? I don't have a clear answer to that question. But in talking to several folks who are working in the field, I think that it's in part driven by concerns about a diversion of opioid use disorder treatment medications. And so in addition to weighing these issues around appropriateness of care and cost control, I think Medicaid managed care plans, and I'd say more so in some parts of the country than others, are also taking these concerns about diversion into the decisions that they're making about utilization management. And I think that that is an important area for study as well, because we have no evidence around those issues at all. So, to be fair, managed care plans face, some pretty significant challenges to facilitate access to high quality care because they're operating within these, pretty significant financial constraints that are really defined through their contractual agreements with the states. And it's also the case that these kinds of limitations can be very important and useful tools for ensuring appropriateness of care. But at the same time, we do have some recent research from Tammy Mark and others indicating that when Medicare, for example, passed a policy disallowing prior authorizations for buprenorphine, they found clear evidence that utilization of that medication went up. So I think that's something that's pretty important to pay attention to. We've also seen some recent work on the Medicaid side trying to examine the effects of prior authorization policies on the fee-for-service side and looking at how that influences utilization. But what's tricky there is what we've just been talking about, right, is that 75% of enrollees are in these managed care plans, which may have policies that mirror what's happening on the fee-for-service side, or they may not. So it's difficult to draw conclusions there. I also think it's going to be important for us to think a little bit more carefully about these utilization management policies, not as in this sort of dichotomous way, they do prior auth or they don't. There's a lot of variation in the structure of these policies that could have pretty significant ramifications for how they actually influence outcomes. So we need to ask questions like what kind of information is required in that prior authorization, who must provide that information, what medical necessity criteria are being used to evaluate the request, how much time it takes the plan to make a decision. So I could go on and on there. So that's an area where I think we really need to continue to pursue further research. One of the things that we're working on with our team right now, with support from the National Institute on Drug Abuse and the National Institute on Alcoholism and Alcohol Abuse, is a study where we are taking the data that we've been gleaning both from the Medicaid managed care plans as well as state regulatory policy and linking that to Medicaid managed care claims over a 5-year period of time to try to understand, okay, we know there's variation, we know there are gaps, but what is the impact on enrollees' ability to access treatment, remain in treatment, and then looking at more downstream outcomes like risk of overdose and death. So we're really passionate about that work, and hopefully we'll begin to publish on that within the next year or two.
Well, I really appreciate the nuance in your response to this last question, particularly moving away from sort of a 1-0, is there utilization management or not? The fact is that the origins of things like prior authorization come from overutilization, or as you noted in this context, potentially diversion, and elimination of those provisions has consequences that aren't just about saving money, but are actually about assuring that people get appropriate care. And so our ability to have a regulatory regime where the state and the plan are hopefully working together to define the criteria for receipt of these benefits could potentially actually maximize appropriate utilization and minimize inappropriate. Of course, that's a fine balance to achieve, and we're certainly not there, and we're not. It's not easy to get there, but thinking of that as the goal rather than simply the elimination of all barriers as sort of the end state that one would prefer is probably more realistic and will also help us generate the evidence to figure out what types of barriers are most profound and what, as you note, the actual health consequences are in the end state of people living or dying or having their substance use disorders under control or not. That's really the goal we should be looking for, and these are all just the pathway there. So.
Well, and I think that can be tricky as well. There's definitely a lot of discussion in the field about just how harmful it is for a drug like buprenorphine to be used outside of a prescription. If an individual has an opioid dependence and they're making a decision between taking buprenorphine that they obtained in the illicit market versus fentanyl, a lot of folks in the harm reduction community and the treatment community would say, it's hard to argue with the fact that buprenorphine would be a safer choice. And so I'm very sympathetic to that in many ways. But I think one of the challenges is I suspect there's been some level of disconnect between folks that are making decisions on the insurer side and folks that are working in the field and thinking through the best ways to navigate that complex concern.
Well, that seems like a good place to wrap the conversation up because it's trying to the extent possible, align the evidence with the realities that are on the ground and the realities that the plans and the state Medicaid agencies face. That's the challenge of the day. So, Dr. Andrews, thank you so much for doing this important work, for explaining it with such clarity and nuance, and really bringing this complicated issue to life. Thank you so much for being my guest today on A Health Podyssey.
Absolutely. It's been such a pleasure to talk with you.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.